Hello everyone, we'll start in another 5 minutes. We'll be starting in another minute.
Hey, Akash, you're muted.
Am I audible?
Oh, good. Are you having a nervous breakdown because I'm late?
I'm used to it now, not an issue.
All good, all good. Got internet today? Got the right
Yeah.
link?
I have a nervous breakdown because I have a 26-weeker twins coming, not because
Oh,
of
man.
feeding it.
Okay. No, that should be cool. Come on. All good.
Yes,
Thank
hope
you
so.
for the invitation.
I welcome you, Dr. Julie, and I welcome all the participants from across the world. Good morning, good afternoon.
Hey, you
To
got one more minute, man.
Yeah, I'm sparing that minute for you.
Okay.
So we welcome you all to this last lecture of Neonatal Master Series 3. And today we have with us very eminent speaker. She needs no introduction. You all know her. She is Dr. Julie, who is at neonatologist at Royal Hospital for Women, Sydney, and is also a conjoint professor of pediatrics at University of New South Wales and a visiting medical officer in addiction medicine. We have recently listened to her on the topic mild hypothermia, and today she's going to take us through neonatal abstinence syndrome. Over to you, Dr. Julie. Hearty
Oh, you want
welcome.
to start already? Really?
We are on time.
Oh my God, you are scary. Okay. All right. Okay. No leeway here, man. All right. I'll try to share my slide. I hope it all works. Cool. All right. Can you see my slides?
Perfect.
Lovely. All right. Noise. Okay. I'll do a slideshow. All right. So thanks, Akash. You're a very strict timekeeper. And thank you for the invitation to speak on how prenatal drug exposures impact our little babies. It's not something that we normally consider, I guess, coming from Asian backgrounds. It's not a high priority area in our work, but I guess increasingly is something that we need to pay attention to. And the global impact of prenatal drugs is now considered such an enormous issue that the United Nations and the WHO have taken up the drive to look after babies and the long-term impact that the prenatal drugs have on them as they grow up. So a disclaimer, I was part of the UNODC working group that met last month and presented at the Commission for Narcotic Drugs in March. And we are a group that was convened to look at 3 aspects of prenatal drugs on children. I am leading the health strategy, and 2 Americans, Henry Jones and Mishka Terplan, are leading the social and the economic strategies. So I'm not sure whether this area is familiar to many of you in the audience, but please type your questions on the chat pane and I'll try to answer them at the end. So let's start by the history of what we think as a medical profession of what prenatal drugs do to children. So when it first came into our awareness more than 50 years ago, when Loretta Finnegan developed her Finnegan score, it was considered that it may be a possible problem. Prenatal drugs may cause irreversible changes to the developing child, and that it was very important that we allocate time, money, and effort to study the long-term effects on central nervous system functions on the child exposed to prenatal drugs. But just a few decades later, in the 1980s, there was a complete turnaround. And the general sentiment then was that prenatal drugs did not appear to cause any developmental sequelae, although the children didn't develop quite as well as the non-exposed children. So why did we think that? We're not sure. But fast forward to a couple of years ago, and there was a very strong editorial saying that prenatal drug exposures causes long-term developmental changes, whether it's from the drugs and the other environmental issues, we still don't know, but we know for sure that if you have a baby that is exposed to prenatal drugs, that there are concerns. And I'll explain why. So prenatal drugs causing neonatal abstinence syndrome, or NAS, is not a new phenomenon. So it was first described in Western literature way back in the 1870s, and it was called congenital morphinism because that was a drug that most mothers use, morphine. So even way back then, it was known that these babies were born otherwise very healthy and normal, but then they started withdrawing in a few days, and their course was devastating. So in one very tragic case, one mother had 16 babies and 15 died from withdrawal. And the only reason that the last one survived was because someone worked out that this baby needed a bit of morphine, and it got morphine every other day and it lived. So for decades, we were concerned about treating NAS because it was a devastating problem. 9 out of 10 babies with untreated withdrawal from morphine or opioids that were used by moms those days died. This is a higher mortality rate than we have for our 23-weekers admitted into our modern NICUs. So I'm not sure, I hope this video works. For those of you who haven't seen a baby withdrawing before, this is classical. And I have to say, I've been given permission by the families to use these videos for teaching purposes. So this little girl was exposed to a variety of substances prenatally. In her case, it was, I think, gamma hydroxybutyrate and assorted opioids, as she was tremulous and jittery like this for months. Okay, I need to move on to the next slide. However, what we have now is that we have improved our ability to diagnose and treat neonatal withdrawal, and NAS itself is now an uncommon direct cause of infant death. So our question is, what happens to these children? So there are thousands and thousands of children exposed to prenatal drugs all around the world, even in your own countries where it's not a very common phenomenon that moms will admit to. So looking for a child with prenatal drug exposure is like looking for Wally in this picture. And this is because acquiring data from them is difficult. They're very mobile. Many are difficult to engage because they have very difficult social circumstances. They look brilliant, they look very healthy, but what neonatal abstinence syndrome and the pregnancy problems related to prenatal drugs is a marker. It's a tip of the iceberg problem. So what it overlies are the many issues that go on for life that you seldom see until the iceberg melts. So remember that anything taken by the mother, including drugs, will cross the placenta. And the trouble with prenatal drugs, many of them, is that they do not cause overt abnormalities like alcohol here. So alcohol, as you know, is a fetal teratogen and is the only addictive substance that is confirmed to be a neuroteratogen. However, what prenatal drugs do is they have a very subtle but long-lasting impact on brain growth and development. If you take opioids, for example, if I give a little baby opioids, I will disrupt myelin production, how long the dendrites are, how the axons branch, and then you will end up with short and simple dendrites. Opioids also increase neuronal death by apoptosis and necrosis, whether the patient is a developing fetus or a grown adult. If I gave you morphine as an adult for a couple of days, your cognitive function will rapidly go. Indirectly, opioids and other substances such as stimulants will increase vascular contractility, causing hypoxemia to important organs like the brain and the placenta. And many of them stimulate their drug receptors, such as opioid receptors, which are negative growth factors. So often children who are born to opioid users or other drug users are small in weight and small in head size. So in this experiment, little rats were injected with heroin intraperitoneally. And what you can see here is that there was selective hippocampal neuronal apoptosis. And the hippocampus is the part of the brain that governs memory. So when you get our children growing up, the ones that have been exposed to opioids, they often have difficulties remembering the task that you give them. And it needs to be a very selective learning process that will overcome this prenatal deficit. Furthermore, drugs act on the endogenous neurotransmitters. These are the substances, as you know, that allow signals to cross from nerve cell to nerve cell. They're made from very simple amino acids that are readily available in diet, and many of our moms who are drug users are also malnourished. The neurotransmitters are made in the brain reward centers deep in the brain there. And the more you use drugs, the more neurotransmitters are released, and sooner or later, the neurotransmitter neurons and the receptors in the brain reward centers are exhausted. So opioids and many other drugs are also inflammatory mediators, especially in the brain. Neuroinflammation is now acknowledged as one of the most important mediators of poor mental health that can start prenatally. So we'll just focus on opioids, and how they increase neuroinflammation is by activating opioid receptors in immune cells. They activate the toll-like receptors, which are integral to systemic and central inflammation. And they activate the glial cells, which are the immune cells of the brain. And this is associated with opioid tolerance and side effects. And of course, neuroinflammation is also exacerbated by the other problems that are very common in substance use, including stress, malnutrition, and other physical health issues. So this very complex site shows you that prenatal drug exposure is not the only problem facing the children that are exposed to drugs. So on the left here, you have the direct drug effects in blue, which dysregulates neurotransmitters, causes NAS, which leads to postnatal stress. You get peripheral hyperimmunity and then environmental stresses. And in the middle there, you have the activation of the central and the peripheral immune system with increased inflammatory cytokines, which cause brain inflammation and injury. And on the right side, you can see the indirect effects, the stuff that cause maternal inflammation, changing of the epigenetics, which is another lecture in itself, disruption of the HPA axis in the mother, leading to pregnancy complications, and of course, right at the bottom, where we contribute to the poor outcomes of the children with lack of timely identification, intervention, and support. And all this leads to what is in the bottom, poor brain growth and function, and poor life outcomes. So what happens in real life to the babies who have been exposed to drugs? We can't chop off the skull like here, so we can do other things. So in this project, a couple of my very, very clever medical students did MRIs on about 30 babies who are exposed to prenatal opioids and other substances. We would have loved to have done control MRIs, but we didn't have the money for it. So we wrapped the babies up, they went to sleep, and we did an MRI. We hypothesized that these babies would have structurally normal brains, but knowing the effects of opioids on brain growth, small brains. But we didn't expect to find what we actually saw. So we divided the groups into two groups. So we had babies or moms who used only one opioid. They were stable on an opioid treatment program in orange. And we compared them to babies or moms who used multiple opioids. So methadone or buprenorphine and assorted other opioids. So this is what we found. So to explain the slide, on the left axis here is the brain volume of the babies, and on the bottom, whether they use more than one opioid in red and not more than one opioid in orange. As you can see here, the brain size or the brain volume of the babies or moms who use multiple opioids was significantly smaller than those of babies who use, of moms who use only one opioid. It's a multiple, sorry. But compared to normal term baby, healthy, unexposed brain volumes, these two groups have significantly smaller brains. And smaller brains on a population level is related to cognitive ability. And what we found was that they also had very small basal ganglia, which is the seat of all neurotransmitter production, and tiny cerebellums, which apart from coordinating smooth body movement, is also increasingly implicated in cognitive function. So there's lots of neuroimaging studies now coming up of children and adults exposed to prenatal opioids. And what we are learning is that the impact of prenatal opioids and other substances on these patients are long lasting. So what we find with decreased cerebral perfusion, abnormal connectivity, reduction in brain volume, smaller cortical surface areas, abnormal microstructure, and other functions persist until adulthood. So these are some examples of MRIs that you can see in children who have been exposed to prenatal drugs, such as white matter punctate lesions, diffuse white matter injury. We did a meta-analysis of our cognitive studies that have been done on children over 30 years. And what we found was that in more than almost 1,500 children with prenatal exposure, by the time they reached school age, they had cognitive function that was equivalent to 8 IQ points lower than other children. So what does that mean in real life? It means that they were 3 times more likely to be classified as intellectually disabled by DSM criteria. So what we are missing now is the opportunity to identify these children from infancy. And we are increasingly using the test general movements assessments that many NICUs use to identify children at high risk of cerebral palsy and global developmental delay, such as in very preterm or sick babies, like hypoxic babies. We have done a small study, and what we found was that in 8 opioid-exposed infants, we could only find 1 that was normal, that had normal general movements. This is a pretty long video, but you can see here that this child has a paucity of movements. And, we had our team talking a lot in the background. We were very noisy, and there was very little movement. And what the Cerebral Palsy Alliance is finding is that there are an increasing number of children who have had a history of prenatal drug exposure referred to them for early intervention for cerebral palsy. So this is another little boy who was born to a mom who had a very tortured prenatal history and used quite a lot of methamphetamines. And although he looks quite normal, you can see here that he doesn't move his left side very well. And he had, I think, an MCA and an ACA stroke. So this child was referred directly to the Cerebral Palsy Alliance for intervention as soon as the general movements assessment was done. So in the grand scheme, what happens to children or adults with a history of neonatal abstinence syndrome? In the United States, at conservative estimates, approximately 1 in 15 children are born. One child, is there someone talking? Sorry. 1 child is born every 15 minutes with NAS. So the most comprehensive study that has been done so far was published way back in the 1950s. Kobrinek et al. Looked at almost 200 babies born from 1875 to the 1950s and found almost 170 alive. So what he described was quite sketchy. There were 3 that were known to be addicts, one starting at the age of 10 years. 1 was sickly, 1 was blind, 1 was deaf. And on the right side, you can see the sentiments that were expressed in this publication, the stigma and the discrimination that pervades our treatment of children who have been substance exposed. So things like, after early successful therapy, it has been urged that the infant be taken immediately and permanently from the mother because this is the best as it is rare for an addicted mother to make a permanent recovery, and newborn addicts are the only curable addicts. So I hope that these are not words that you would use yourself in today's practice. We need a life map to find where all these thousands of children have gone to, so we can identify points where we can help them. And we're very fortunate in our state of New South Wales in Australia to be able to conduct data linkage. So if you don't have that in your own environment, what data linkage is that it is an administrative method to link databases such as birth records to hospital data, death data, school data, whatever data you want, through identifiers such as your names, days of birth, addresses, hospital numbers, whatever. So this is a slide I show the Europeans to show how big Australia is. And as you know, we've had one of the toughest lockdowns in the last couple of years. No one could escape. So we can find you. And New South Wales, again, to show the United States that we're the size of Texas, but a lot less people. And so we can also find you very nicely. Each person in New South Wales can be linked through administrative data up to 8 times currently. So one of my very clever medical students called Hannah Ubel, way back when, did a study where she linked more than 1 million births in New South Wales in our state and found almost 4,000 infants with NAS who were diagnosed with P96.1, which is the ICD-10 code for NAS. So she compared them to other children, 1 million of them without NAS, and tracked them to 12 years. Currently, we're waiting for data for the children up to 20 years. So this slide, this table shows the characteristics of the mothers with NAS in our state of New South Wales. Yellow and blue are the NAS moms. Very expected findings. They're younger, they're more likely to be Indigenous, smoked, no antenatal care, and of the lowest socioeconomic quintile. So these children are born in a tragic circumstance already. The babies, again in blue and yellow here, more likely to be low birth weight, preterm, poor APGARs, admitted into an NICU instead of staying with the mother, and stayed 3 times longer than other children. So these are all known things. But what happened to these children after we fixed their withdrawal, which sometimes takes only a couple of days? What we found was that children with NAS kept coming back into hospital. And the risk of hospitalization continued until they were 12 years old. So in this risk graph, you can see that the green line representing NAS children is consistently higher than the blue line representing children without NAS, showing that their risks of coming into hospital remained even though they were after teenage years. And they kept coming in for very tragic circumstances, not illnesses. So they kept coming in for things like injury, burns, poisoning, accidents, and assaults. And they kept coming back into hospital at younger ages, 4 months compared to 11 months for these tragic circumstances. After looking at all the other factors that could be independent risk factors for all these serious problems, what we found was that NAS was associated with a 4.5 times risk of a child being hospitalized for assault, even taking all the other risk factors into account. They also came in for evaluation of mental and behavioral problems. But as you can see at the bottom there, they came in at a significantly older age, 5.5 years, compared to 3.5 years, suggesting that these issues were not picked up until the child went to school. And in a recent study from the United States of more than 1,000 NAS children, what this group found was that by age 5, 1 in 2 had a diagnosis of a mental health disorder. So I'll skip that. And the other question is, are children with NAS more likely to die? And they were not more likely to die in hospital, but between the age of 1 month to a year, they were 8 times more likely to die, leading to a death rate in New South Wales of 3 times higher than other children. So the question was, what did they die from? And again, the risk of death it was consistently higher until the age of 10 years. This is an inverse graph, and you can see here it represents survival. The red line representing the NAS children is consistently lower than the blue line representing other children in New South Wales, even until adolescence. Unfortunately, the causes of death were mostly unclear in many of the children with NAS. Normal children often die of a known problem, like a heart problem or cancer or brain problem. These kids turned up dead, and they needed autopsy more than other children. And they don't die of medical problems. They die of uncertain causes, such as sudden infant death syndrome, and again of external causes, such as accidents and assaults. All these are preventable problems. So does prenatal opioid exposure or exposure to any drugs impact on life expectancy? Every life that is curtailed prematurely is a loss on society. We don't really know. We hope to do more data linkage studies to find out, but the study of people with fetal alcohol syndrome, or FASD, in Canada found that life expectancy for people who had been prenatally exposed to alcohol was only 42% of the population. They died at an average of 34 years of age, and mostly from external causes like suicide, mental and behavioral disorders, and cardiovascular and other health issues. Okay, time is running short, so I'll quickly go through what happens at school. School is one of the most important achievements of any child, right? If you don't do well at school, you get physical problems, mental health issues, it's more likely to be prone to psychological problems and societal adjustment problems. So the children after NAS have multiple risks for poor learning. That's the effects of the drugs themselves on brain development and function, the effects of the parents. Many of the parents have psychiatric and health comorbidities. They may have lower parental education and often genetic and epigenetic changes from all the multiple associations with drug use. And often there are also social problems. Many of these children move a lot of schools, they don't have a stable home, they're poor, they can't buy books, and they're poorly nourished, which impacts again on neurodevelopment. So in Australia, we have the very much maligned test. It's a standardized test called the NAPLAN test, which stands for the National Assessment Program for Literacy and Numeracy. It's and it was introduced more than 14 years ago. The test is taken every year in May. The results are available in September, and every child is assessed 4 times in the school life, starting from the ages of 8 to 9 in grade 3. So the NAPLAN test has 4 domains: reading, writing, language, numeracy, very familiar to all of you who are parents. And it's quite a simple test. It's aimed to identify children who don't meet national minimum standards, which is about 1 in 5 at the most of all Australian children. Exemptions are very uncommon and only given if the child is very sick or newly arrived from a non-English speaking country. So in our state in New South Wales, more than 95% of children will sit for the NAPLAN test. So this is a NAPLAN report. It's a standardized test, which means that each score at each age represents the same level of achievement. So the test is divided out of a score of 1,000 into 10 bands, as you can see on the left here. And the child is tested 4 times in grades 3, 5, 7, and 9. 7 and 9 is our high school. So as the child grows, the scores go up as the students get older and gets more ability. All right, shall we mute first? Thank you. All right, so the children who don't meet minimum standards at each level, you can see that each level's minimum standards is different. They are considered not to have the skills to proceed on to the next level of schooling. So they need help. So what happened to the NAS children? So in Hannah's cohort, she found more than 600,000 children who went for the NAPLAN test. And then she found more than 2,000 children with NAS in red, and she matched them 1 to 2 with socioeconomically, gender, and gestation matched controls, and compared these 2 groups to the population in green of other New South Wales children. So what she found was that the children with NAS were 20% more likely than the rest of the population or controls not to have a NAPLAN record, which means that they were less likely to even turn up for the test. And by the time they were in year 5, which is about age 10 to 11, 50% of them had not met minimum standards compared to the most 20% of the other children. But what was really tragic was their scores as they got older. This graph represents their scores on the left axis out of 1,000, and on the bottom x-axis is their grades. So grade 3, 5, and 7 in high school. The top line represents children of New South Wales, the middle line, the controls, and the bottom line, the NAS children. You can see here that the children with NAS have lower scores than other children by the time they do the first test at the age of 8. The scores remain low, and by the time they reach high school, their scores are lower than children in year 5 who are 2 years younger, which means that children with NAS have scholastic abilities that deteriorate as they age. So it's well known in many parts of the world, especially in the United States, where there's a huge opioid crisis, that prenatal opioid exposure or exposure to any drugs of addiction increases the need for education support. Increased education support also exists even for treatment with prescription opioids. In many parts of the world, including states like Tennessee and West Virginia, 1 in 5 children with a prenatal history of drug exposure need disability evaluation, and 15% meet criteria for disability, which is as high as many of our sick preterm babies. So on that note, I'd like to introduce you to my friend Floyd, who was born at 24 weeks gestation when I was a young fellow in 1998, and he weighed 500 grams. So in those days, we didn't give Floyd much of a chance of survival. He was a boy as well. So maybe, 1 in 2, he would have made it out of our nursery alive. In the same year, we had Robert. Robert was born at full term, and he had neonatal abstinence syndrome. Uncommonly for Robert, he had 2 very loving parents, Jenny, and I think his name was Dave, Dad, and they were together for a very long time. We treated Robert's NAS, and his chances of survival was more than 95%. So we looked at Hannah's data of school outcomes, and we found 3 groups of children. So can you, if I were with you in an audience, I would ask you, who do you think do these scores belong to? Which one's Robert's, which one's Floyd? So you can see here the top line there belongs to children who are born at term in our state of New South Wales with no known exposures or other medical issues. The second line, the dark green line, belongs to people like Floyd, who had more than a 1 in 2 chance of dying from extreme prematurity. And the bottom line belongs to the full-term babies with NAS, like Robert, who had more than a 95% chance of survival. Their school scores are even worse than the very extremely preterm babies. So what happened to them? So fast forward 16, 17 years later, this is Floyd. He's gone on a school trip to Vanuatu. He's very cranky. He's a teenager, but I think he's doing quite well. And what happened to Robert? Unfortunately, mom's died, Jenny's died, dad died a few years later, and we're not sure what happened to Robert. So there's lots of money being poured into research programs all around the world, especially in the US and in Canada. The National Institute for Drug Addiction, NIDA, and National Institute for Health in the US has just poured in 53 million for the HBCD study, which stands for Healthy Brain and Child Development. So they aim to recruit more than 7,500 pregnant women to understand brain development in pregnancy and in infancy and with other substances. So a subset of these will be exposed to opioids and other things such as COVID. This will take a long time, and we will have to wait many years to get some results from this study. So in the interim, what we're working on globally is to gather global attention to understand and to pour resources into making sure that these children are not left behind. We know that they're exposed to drugs. That is one of the most important risk factors, and we must work together as a medical and a social community to make sure that these children do not get lost. So in conclusion, I've done some time catching up. So there is increasing concern that prenatal opioids or other problems associated with other drugs will increase the risk of mental health, neurocognitive, and physical problems in the children. We need to identify urgent knowledge gaps, including how we find the infants, how we intervene to support mothers and infants, and improving the care, the knowledge of the care providers, including knowledge for parents and the older children and adults who are now surviving the history of prenatal drug exposure. We need to understand the long-term concerns, especially for adults with a history of opioid and other drug exposure, so that we can work with them to prevent what's happening to them happening to other children. So on that note, I will end and thank you. And if you have any more questions, please email those addresses on the bottom, and the website for the opioid strategy for the UNODC is on the bottom right. So happy to take questions now. Thank you very much for your attention. No questions? Dr. Akash, I think he's gone to his 26-week deliveries. I think Dr. Akash is, maybe we can come to an early mark, eh? Let me WhatsApp him. So has anyone got any questions online? Bonnie Baracho said, what is the impact of a neonate born to a father with history of drug and alcohol addiction? So that's the major mystery of life, Bonnie. So we know that there are impacts, especially epigenetic changes. So what that does in one generation may not be immediately obvious on the newborn infant, because obviously the infant's not withdrawing or showing other direct drug effects. But then after that, there can be epigenetic changes to the sperm, anything that could transmit to future generations. We know that a predilection for substance exposure will run sometimes, even if it's only the father that used the substances. Dr. Nalini says, thank you. Is there a support group for mothers who have opioid use in your place or programs in the antenatal period? Yes, Dr. Nalini, we do have massive investments in substance use issues in pregnancy and parenting. And Australia is very lucky to have a harm minimization approach to their treatment of moms with substance use issues. So we have a lot of ministry support and a lot of social support to make sure that our moms, get the best antenatal care and the early childhood support that they need. I think it's a very lucky country compared to other Western countries, including the United States, where it's quite punitive in many states. So it'll be interesting to hear from you in the audience, especially from Asia, how you manage the issues that you see with moms using substances. Anyone want to comment? No? Okay, we'll move on to Pungandran. It's a direct message to me. If you guys can put on the chat pane your messages to the whole group so other people can see. Yeah, that'd be great. Mispronounced the name. Said that have there been any studies on postnatally opioid exposed babies on their neurodevelopmental outcomes? Yes, there are many, and but they're very sketchy, and most of them don't go beyond school age. So what we're hoping to do is to extend. Oh, Dr. Akash has disabled text to everyone. That's pretty nasty. Sorry, guys. I'll just keep reading out the messages. So our cognitive understanding on postnatal development is quite sketchy, and that's where a lot of the research money is going into, to look at them as a cohort for an extended period of time, taking into account other associations. So Dr. Akash is disabled messaging to everyone, and he's disappeared. Okay. All right. Any more questions, guys? Okay. So Dr. Pungandran again says that we know the use of Finnegan scores to look at withdrawal symptoms for opioid-exposed infants, but are they useful in preterm babies? Thank you for that, because that's a major problem that we have. For those of you who are unfamiliar with the Finnegan score, it's a score that was developed in 1975 by Loretta Finnegan, based on observations of, was it 21 or 26 opioid narcotic exposed babies? And it gives an indication of when babies need medication for withdrawal. Unfortunately, over the last 50 years, we've used the Finnegan scores for a lot of other things, including very preterm babies and babies exposed to other substances such as cannabis or amphetamines or alcohol or even prescription drugs. So unfortunately, the Finnegan score is not useful in preterm babies who have very low scores because they don't have the neuromuscular maturity to manifest scores as a term baby. But that doesn't mean that the preterm baby is not withdrawing. So I could give you another lecture. I could talk for about 3 days on the Finnegan score. But if you want to find out more, just email me. Thank you. Okay, so from Agnes, I really, we're very sad that you guys can't see all these messages. I'm going psycho trying to moderate them without Dr. Akash. I will get him afterwards. So Agnes would like to ask about their neurological findings. She has a patient with NAS and persistent hypertonia, at 2 weeks, even on oral morphine. The other symptoms resolved after the baby was started on morphine. Do we continue the oral morphine till the hypertonia resolves? And if the hypertonia persists, is it highly possible the hypertonia was caused by permanent damage due to maternal morphine use? So Agnes, that's a good question. What we find is that babies who have been exposed to prenatal drugs, especially opioids, may be quite stiff for many, many weeks, even up to 6 months. And if you look at animal studies, some opioids such as methadone can persist in the infants for months. So in our service, what we do is we will taper the morphine, the morphine or the withdrawal medications according to symptoms experienced by the child and not just on the tone. So if the child is eating, sleeping, and comfortable, then we will reduce the morphine. So if the baby is happy, as you suggest here, then what I would suggest is that you wean the morphine slowly, and the hypertonia, especially in the lower legs, may take some weeks to months to resolve. So I hope that answers your questions. I think you guys can unmute yourself and ask the question if you want to, unless Dr. Akash has also disabled that one. Dr. Rahul is unmuted.
Yeah,
Are you guys unmuted and are you guys like, all right, Rahul, what do you want to ask?
I don't know. I just checking if I could unmute.
This is a good experience. All right, anyone else? So everyone, if there are no other questions, you're welcome to contact me outside of this forum. Just email me. Dr. Akash has my contact details, and happy to talk further if that's an issue that you're seeing in your own practice. So unless Dr. Akash pops up inadvertently, I might end the meeting. Bye.